Hey there, it's Joe. Really quick, before we begin today's episode, I wanted to let you know that my latest book, Radical Relief, is now a #1 bestseller on Amazon in the category of chronic pain. So a really big thank you to all of you who ordered it and for your continued support for this show and the great speakers that appear. If you haven't picked it up yet and you want to learn the secrets of the mind and how to use mindfulness and acceptance approaches for the treatment of chronic pain, then Radical Relief is for you. It's now available on Amazon and in most countries around the world, or by visiting the Integrative Pain Science Institute.com. So once again, thanks so much for your support and enjoy today's episode.
Welcome to the Healing Pain Podcast with Dr. Joe Tatta. Each week, we interview top experts in physical therapy, pain science, and integrative pain care. You'll learn the most up-to-date information for treating and reversing persistent pain. This podcast is for educational purposes only and not intended to be used as personalized medical advice. And now, here's your host, Dr. Joe Tatta.
Hey there, thanks for joining me and downloading this week's episode. Today marks about the halfway point in our Radical Relief podcast series, where we're covering 3 time-tested and science-backed approaches for the treatment of chronic pain, which include pain neuroscience education, mindfulness, and acceptance and commitment therapy. Today's episode really focuses on the evolution and the nurturing of mindfulness-based physical therapists. So starting to train and embed mindfulness both as a process as well as a treatment approach for physical therapists. Today, I'll be speaking with Dr. Annette Willgens about mindfulness. She is a clinical associate professor in the Department of Health and Rehabilitation Sciences and the Program of Physical Therapy at Temple University. As Director of Admissions, her scholarly agenda includes physical therapy student success, resilience to stress, and effective domain skills across the curriculum. Annette has published 2 papers on mindfulness for the student physical therapist and its impact on resiliency and usefulness in clinical practice. On today's episode, you'll learn about the neuroscience supporting mindfulness, how mindfulness works, and why training in mindfulness is important for both student physical therapists as well as licensed physical therapists out in the field. Okay, as I mentioned before, this is a pivotal episode in our Radical Relief series with regard to mindfulness for physical therapists and other licensed health professionals. Let's begin and let's meet Dr. Annette Willgens. Hi, Annette. Welcome to this week's episode. It's great to have you here. Thanks for joining us.
Hi, Joe. It's great to be here. Thanks for having me.
On the evolution of the Healing Pain podcast, we've talked a lot about the mind and the influence of the mind on the body and vice versa, how the mind can influence the body. People who listen and follow this podcast are very much interested in mindfulness and mindfulness-based approaches. As a physical therapist, I'm curious to hear how you first became interested in mindfulness.
Great question. So I was a new faculty member. I had taken on a position as assistant faculty and the role of the director of clinical education. And I thought, how hard can this really be? And I place students, they're happy, I watch them learn and grow. Well, it wasn't like that at all. My office became sort of a revolving door of students with concerns about anxiety, depression, eating disorders, parents divorcing, ill parents, essentially students experiencing pain. And at the same time, students had, I learned that students would struggle in clinical education courses. And every year there was a couple of students that would be unsuccessful in the clinic. And although 2 students doesn't seem like a lot, it would take over about 75% of my workload to just manage those 2 students. And it was hard to watch. These students were really good people. And, coming to the end of a grueling education and at risk for failing out. So my dissertation topic at the time became, how do these very bright, capable students fail? And my first publication indicated that they fall into 2 really big categories. Students with kind of a baseline anxiety, worry, emotionality, rumination, perhaps imposter syndrome. And then the other was really this concept of just they would turn off their emotions, turn off or hit the delete button, if you will, for feelings, worries, and thoughts that would arise. And so the remediation for these students was my role, and I was really lost. And a colleague at the time had said to me, "What do you know about mindfulness?" And I said, "Nothing." So I went and read everything I could possibly read and took courses and got certified as a teacher.
It's really interesting. When I think back to when I was in PT school, which was in 1995, we knew there was a high amount of pressure and stress. Some of it placed on ourselves because many who are involved in physical therapy or get into a program are highly achieving individuals and intelligent, as you mentioned. And some of it's just stress based on the amount of content that we're required to learn for, to be effective as professionals. But it's interesting how lately there's more and more in the physical therapy literature showing up about stress, anxiety, depression within PT students. So I want to first thank you for your work as I go into the literature and look at some of that work with regard to student burnout. Your name is one that rises to the top, especially with regard to mindfulness. There's only a couple of mindfulness articles with regard to PT students. One particular that you wrote, I want to point people to, is in the Journal of Physical Therapy Education, 2016. We'll link to that in the show notes. It's called Physical Therapist Perceptions of Mindfulness. Why did you decide to write that paper, and why was it important?
This paper was just a wonderful opportunity to connect with students. So students came to me and said they want to study mindfulness because I had been, based on, students struggling, I had begun kind of infusing mindfulness practices into the curriculum. So I would start the class with a pause or a moment of stillness and ask students to check in. And so they really liked that and wanted to do more. And they had been through the first 2 clinical courses and said, why is this not out and about? Why do clinicians today not know about this? And more so, why do they minimize it if we bring it up? So they were really curious. So this was the culmination of a student group that basically wanted to study it. So they created a booklet and once a week would sit down with their clinical instructors and talk about different lessons that pertain to mindfulness. And so the first was just definitions. What are the medical benefits? What's some of the research out there? And then each week they would talk about a specific topic. And what unfolded was really neat, and that a lot of the clinicians out there realized just how much they plow through life. And we all do it at varying points in our lives. I'm just as guilty as anybody else. And that's kind of how it all unfolded.
And as I look at that paper, there are a couple of different themes that emerge from that paper. I'll read them off here so people can have an idea. But the themes that emerged from that paper were, one, the need to fix this. Mm-hmm. The second theme, which was to pause, and as I pause, I notice that this is hard. The third theme was that mindfulness works. Nice to hear that. And the fourth theme was I need support. Can you tell us a little bit about each of those themes and what it really told you about the outcomes from the study?
Yeah. So that first theme, the need to fix, is kind of a universal thing. We are fixers. We're physical therapists. We help people. Yeah. And the need to fix when things are not necessarily fixable can be a really difficult experience. And so when we're not able to fix, that's really where the stress comes from. So it originates in that felt sense of needing to do something more than what we're capable of doing. And there's this concept of emotional empathy as compared to cognitive empathy. And I teach my students about that because I think that we get kind of sabotaged by being led to believe that we can fix everything. And we're really uncomfortable with discomfort. We're really not okay with being uncomfortable. And if there's anything that this practice has taught me, is that that's the most important thing that we do need to learn to tolerate. The second was about pausing is hard. And that's that concept of, I'm a physical therapist, I'm a doer, I'm a mover and a groover, and it's really hard to stop. And a lot of the participants in the study would share that they would go to bed at night, and these really skilled clinicians had a really difficult time turning off the mind and the constant chatter of the brain and the rumination. And did I do enough today? And so yes, this work is hard. I believe it's the hardest work we'll ever do, is to pause and feel. And we've gotten really good as a society of kind of plowing past feeling and to remain in doing mode. And that's why that theme emerged. Mindfulness Works was basically the small teachings that the students provided these clinicians really did have a profound effect. So some of the clinicians would say things like, well, I turned off the television and it just tasted my food for the first time in maybe years. And I realized that I was full before I'd even finished my plate, because I felt embodied and I felt connected. And it's just like those sorts of things, just really fascinating, right? And so this stuff works. And I think the biggest takeaway from the paper was that you don't have to, sit cross-legged for an hour every day to get the benefits of mindfulness. It can be like brushing your teeth. If you brush your teeth and really feel the toothpaste on your teeth, if you walk and really feel your feet hit the ground, if you notice the sensation of, the air on your skin as you're walking your dogs, those sorts of things, that's mindfulness. And that incrementally changes the brain in a dose-response relationship that's really critical for all of us human beings.
Great points. I want to come back to, I know we're going to talk about some of the neuroscience behind mindfulness, but I want to go back to that first point just for a moment, which the theme was, I need to fix this. In this study, was that statement with regard to I need to fix my internal emotions, thoughts, and sensations, or was I need to fix my patient or the situation I'm in, or is it kind of a combination of all those?
I believe it was a combination of all of those. So individuals would kind of notice the need to fix patients, and notice the need to kind of fix their own responses to the patients. So there was one quote that said, "We're in a very high stress, demanding job. Working with people can be difficult. Any technique that could help us work better with patients, work better with students, reduce stress, I'm all in." So I believe it's that kind of universal sense that we are inherently flawed. We are perfectionistic beings, and that is not sustainable.
Especially for PT students, when there's so much going on, so much change in their life. And PT curriculum has grown and grown and grown from the time I was in school, which is so interesting.
Yes.
So I'm just curious from a professor perspective, because if I were to go to many, not all, but many DPT websites, there's a bit of a theme there that as professionals, we go to school, we achieve this degree, and we have this ability to fix people. Now, a grade 1 ankle sprain, I'm pretty confident I could quote unquote fix that. As I've continued on in my career, and of course, with a lot of the work I've done with mindfulness and ACT, these themes have come up. And I'm just wondering how you communicate this. I mean, obviously it's communicated through mindfulness itself, but do students raise their hand at some point and kind of have a, an aha moment where they say, I'm not sure this is what I thought I would be doing, or this is not the way I thought I would be doing it, as they come across information like you're sharing with them, which they're probably not hearing in other classes and particularly other programs?
Yeah, that's a great question. So my experience has been that if I try to teach students about the complexity of patient care, then I'm not teaching them really from sort of an inside out perspective, and it doesn't land with them. They kind of check out and they're like, yeah, I've got this. I'm going to go teach that, grade 2 ankle sprain. But if I teach it from the perspective of, this is stressful, this is a grueling program, you will have moments of discomfort and failure potentially, then that really resonates with them. Because just, by one example, there's 3 big ticket items I would say that I teach students. One is that your thoughts are not necessarily real. And that's a really great teaching that basically means we tend to judge everything. We like it, we don't like it. It's good, it's bad, or it's neutral. We compare, and we tend to check out of the present moment. The present moment's not really very exciting. It's not, something that we really want to, hang out in a lot. We think about the future and the past. So when students attach to that A, I got an A, that's great. I'm going to, I want that A. That's expectation, that's striving. That becomes the focus of their attention, not necessarily the learning, but the A. And similarly, when they attach to the bad, it's that, oh, I got a C. Am I meant for this? Is this, that becomes the focus of their attention, and the action arises from that felt sense. So without the attention and the awareness, the student gets enslaved or entangled with that emotionality, and they move on with autopilot, which is just kind of that default center of the brain that says, yep, this is how I'm doing it. I'm not going to look any further than myself. And the concept of real but not true teaches them, well, there's a real physiological and even biochemical response. The HPA axis, all the things we know about the sympathetic nervous system response. There's a bear in the room. There's really not a bear at all. And that's always a big aha moment for them. They realize that they can pause, can reflect, can discern their thoughts and feelings without action. And that is really a breakthrough moment for them. The fact that they themselves can restore their sympathetic nervous system to its proper function is really important. And it becomes a tool. The other thing I teach them is about that feelings have names, and they're temporary and universal. So for example, I start my class with, let me know how you're doing. Put into the chat box the number 1 if you feel like you just want to go back to bed, or number 10 if you are ready, taking on the day, bring it on. And so they see the chat box and they're like, oh, okay, I'm not alone. Look at all these other people that are 2s and 3s and 4s. And it changes the dynamic of the class, and it helps them feel like they're not different. That stress is a normal, universal human experience. So that's huge too. And then when they tell me I'm feeling, anger or sadness, I've realized that students have increasingly few words to discern their experience. And so when they say, I'm really mad about this grade, I ask them, so are you mad? Are you angry? Or is it more disappointment? Is it sadness or is it frustration? And that is another aha moment for them. They are learning that it doesn't have to be all in one bucket, if you will. And there's a great, really funny neuroscientist, Norman Farb, who basically says, why do we have to feel things? Why can't we just think it through? Why can't we be cognitive beings, right? And he's written on a paper on the concept of embodiment, interoception, and the granularity of emotion. And I teach my students all about that. And when they learn that they don't have to kind of be enslaved and entangled with emotion, they say, oh, I see, I get it. If I feel it, I can make the emotion move through me much more quickly than if it stays in my brain space and I ruminate about it for 3 days.
Yeah.
So that's huge. And that really lends itself to self-confidence, because if I can work it through myself and I don't have to call mom and I don't have to call a friend and check in with them, then I'm basically teaching my brain that I can manage things myself.
That piece about interoception is really interesting to me, especially from a physical therapist perspective. So much of mindfulness focuses on thoughts, but there's a whole nother aspect of mindfulness, which is mindfulness of the body, and how interoception, which is the scientific technical term, influences our thoughts. Mindfulness itself has been defined by everyone from yogis to Buddhists to contemplative scholars to psychologists. What's your definition of mindfulness that you like to share with your students so they start to really understand, okay, this is what mindfulness is?
That's a great question. There are some really great definitions out there. I essentially teach them that mindfulness is about present moment awareness of what's going on truthfully for them. The key ingredients, though, are a healthy dose of gentleness and self-compassion without judgment. And that is the single most difficult thing that clinicians, that all of us do, is to try to look at ourselves with gentleness. We do it for everybody else. We're compassionate to everybody else. But it's very difficult to do it for oneself. It's that concept of putting the oxygen mask on first in the plane as the plane's going down. We must do that for ourselves if we can give it away all day long for our patients.
Excellent. How does mindfulness influence patient care? So we're starting to train mindfulness in student physical therapists and potentially even some of our educators who maybe weren't trained in mindfulness, hopefully are going back and starting to say, hey, maybe this has a place everywhere in our curriculum, not just in one class. But how does it eventually influence patient care as we're moving into affiliations and, of course, into clinical practice and further on in our career?
Absolutely. Yeah. So the biggest takeaways from the literature, and these are from really great publications like Medical Teacher and some other physician journals. And those are patient satisfaction, fewer errors in clinical decision-making, higher quality of care. So like refraining from that default mode, increasing curiosity, so that taking the step back rather than jumping to conclusions. Patient adherence, because when we teach this stuff, we get more buy-in from patients because it makes sense to them. It's a big aha moment for them as well. And because of that, there's a direct connection to quality of life. So it keeps them coming back because they feel differently, because they have a different relationship to whatever's going on.
That's really important, especially with regard to chronic pain, because oftentimes when you look at the literature, probably about 25% of people living with pain who engage in physical therapy or other types of therapies for pain never see their course of treatment through. So what you're saying can make a huge impact, of course, for practitioners, but especially for the people that they're treating.
Yes, absolutely. I teach my students to talk to their patients very directly and even draw pictures of the brain and the, 3 levels of the brain, the reptilian brain as opposed to the higher centers of the brain and how those work. And then to talk to them about the HPA axis, the hypothalamic pituitary adrenal axis, and the influence of that on cortisol and stress, because I believe that is where all dis-ease starts.
So how do you break down what is complex neuroscience? If you go into the literature and start to read about mindfulness and how it works, it's very complicated neuroscience. How do you begin to break that down into bite-sized chunks for either your student body or for patients and explain, here's how mindfulness works?
Yeah, that's a great question. So to be oversimplistic, so forgive me in advance if you're a neuroscientist, I talk to my students about the left prefrontal cortex, the happiness center of the brain, and the right prefrontal cortex. The right prefrontal cortex I call the caveman brain or the cavewoman brain, if you will. And it is kind of miserable. He or she is sitting on the side of the road, scanning for threat. There's direct connections to the caveman brain or that right prefrontal cortex to the amygdala, the fight, flight, fear center of the brain. When we tap into sensation, the body, the breath, we disconnect from that right prefrontal cortex and connect to the somatosensory cortex, which is activated and has been shown on functional MRI scans of the brain that shows a dampening of beta waves and a functional shift to that left side of the brain, the happiness center, with more direct connections to the executive functioning, to our ability to make choices that rather than, again, be enslaved by emotion. Interestingly, you can actually change the structure of your brain by pausing, by meditating, even for up to 8 minutes a day. So I teach my students, download an app, Do it right before bed. And if you fall asleep, great. And if you don't, then you've done your 5 or 10 minutes of meditation, of guided meditation. Sarah Lazar out of the University of Massachusetts actually did a study in which she looked at people who have never meditated before and asked them to meditate about a half hour a day. After only 8 weeks, the participants had different brains. Their insular cortex had more density. The insular cortex is that part of the brain that provides us accurate self-assessment. So what is actually happening? Am I doing what I need to be doing right now? The posterior cingulate, which is the area of the brain that has to do with mind wandering, self-focus, became less dense. The hippocampus, more dense. We know that has to do with learning and memory. The temporal-parietal junction has to do with empathy, compassion, perspective taking, more dense. The pons, which is the home of regulatory neurotransmitters, more dense. And the amygdala shrunk in this study after only 8 weeks. So I find that incredibly exciting. And in terms of the neuroscience, there's always really great studies out there.
Yeah, I mean, it's a big body of literature that's continually growing. What's where do you point people to as far as the most important research they should look at if they say, hey, I'm interested in looking up mindfulness, but I went into PubMed, I was kind of overwhelmed. Like, can you shorten my learning curve just a little bit today?
Yeah, absolutely. So there are 3 really important studies, and then a 4th that I'll mention that's my favorite. The first is a study on epigenetics and aging. And that's from Frontiers in Psychology very recently, a number of studies on epigenetics, but this was 2020. And we know that epigenetics is the science of aging gracefully, if you will. And the study indicates that in terms of gene activity, we can't change our DNA, but we can actually change how the genome functions and how it adapts to the changing environmental context that we're in. So it's like the ability to turn down the noise on a dial. And you're literally, if you're turning down the noise on your stress response, then you're changing that genome for the better. And that's by Sabrina Venditti. Again, Frontiers in Psychology 2020. Another really amazing study, we know how prevalent diabetes is and how it really is a public health concern. The Journal of Psychoneuroendocrinology, authors Michael Osborne and colleagues, 2019, he basically looked at amygdala activity, again, that fight, flight, fear center of the brain, and showed how it could predict future diabetes. Not that groundbreaking, right? We know that stress causes disease, but they proved it independent of adiposity. So the higher the amygdala activity in the brain, seen on functional MRI scans, the higher the stress response predicted new onset diabetes, even if there was low adiposity. And of course, individuals in the study with low adiposity demonstrated low amygdala activity and did not go on to have diabetes. But those with high adiposity, with low perceived stress, no diabetes. So
that's so interesting.
Yeah. And it's really what the brain practices lives in the body. The third is the telomere study, which I tell everybody about. Telomeres, as you know, are the protective caps on the tips of our chromosomes. This was a meta-analysis, so highest level of evidence on meditation and telomere length. And this came out in 2019 by Schutt. And so basically he showed that these telomeres are shortened when we have chronic disease and indicate early death and ill health. So people who meditated in this study have longer, thicker, denser telomeres. And that again, there's this dose-response relationship that exists. The more we meditate, the better fit your telomeres have, and the stronger the telomeres are. And then the most important study that I think I shared with a dozen people the day it came out. This is 2017, The Lancet. Ahmed Tawakkol and colleagues, basically was able to show proof of the mind-body connection, which is super cool, as you know. They had an N of about 300 patients without cardiovascular disease or active cancer, and they studied these people longitudinally. They looked at amygdala activity, bone marrow activity, arterial inflammation, C-reactive protein, and perceived stress. Based on the illumination of the amygdala or perceived stress response, they could robustly predict who would go on to have cardiovascular disease. Mm-hmm. So predicting the increased hematopoiesis in the bone marrow connected to increased arterial inflammation in the aorta. And all of these together could let them know who was going to go on to have cancer, stroke, and arterial sclerosis.
Right. So our thoughts have an impact on our physical body.
Absolutely.
That's objectively measurable in studies.
Absolutely. Yeah.
Which I think is so important for physical therapists to key into more and more, and why we're talking about topics like this, because obviously it's part of a biopsychosocial approach to not only pain, but many of the other chronic conditions that you just mentioned that we do treat as physical therapists: cardiovascular disease, chronic stress, all common in our clinical settings. A while back in this episode, I mentioned teaching not only mindfulness in your class, but seeing it kind of spill over into the other classes in your program. And I noticed you perked up a little bit. So it just makes me wonder, how has it been discussing the implementation of mindfulness with your professional colleagues, other professors? And, not everyone takes to mindfulness right away. Sometimes it takes a little bit of time. Some people are extremely enthusiastic about it, but I'm sure you interact with both colleagues in your DPT program as well as other colleagues around the country. How have you started to, just kind of gently nudge this agenda along with your important work?
Yeah, thank you. Great question. I send them these articles. I've actually started a an individual study for students that want to go to take a course and dive into this a little bit more, and practice meditation and be accountable by handing in, practice logs and things like that. And largely the faculty are really supportive. The problem is that there's no room in a curriculum to add yet another thing. Yeah. And I do honestly believe that it's the little moments that, we can all practice moments of stillness, moments of silence. We can teach students these things, especially those students that really struggle in lab exams, lab practicals, and in clinical courses. Imposter syndrome is real out there. And if we can just give them some of these tools and help them find an app that really resonates with them that they can use regularly, I think that's a large part of the battle.
Well said. Over the last couple of weeks, I've been asking the expert speakers on the podcast a similar question, which I'd like to pose to you today. As we learn more about the mind, and as physical therapists, we become more interested in the mind, why at times, and depending on the circles and where we are, why is it a radical idea for physical therapists to use mind training and mindfulness and mental exercises in clinical practice?
Well, as we just discussed, the research is pointing to this robust mind-body connection, and to treat one by itself is not doing our patients justice. So when we essentially teach patients, students, when we ourselves learn that we have control over what we choose to think and the neural networks we strengthen with those thought patterns, we know that stress and negativity lives in our bodies. I tell my students it's like cobwebs that kind of live inside our bodies, our muscles. It camps out, it creates disease. And I always find it really interesting. As PTs, we love to move. We love to exercise. My students always say, "Yep, it's time to go do my 5-mile run, my 10-mile run." And I say to them, kind of tongue in cheek, "So how do you feel after that run?" And, "Oh yeah, I feel great. Feel great." How about an hour later? When those endorphins are gone? Well, yeah, that's when the stress comes back. And then I have to go work out again. And so I think the most important thing is that although the endorphin rush is great, and we definitely need exercise, if we come back to our homes and we are back to rumination, comparing ourselves on Facebook, checking out on Instagram, then we're just practicing more rumination and fear and worry. And so to come from a place of steadiness and to learn to come from a place of not succumbing to fear and worry, I believe we need both. And that's where I beg them, let's all download this app and let's do a meditation challenge this semester. There's a great study that's 2017 by Edwards and Laprinzi, and they did a review of randomized controlled trials looking at exercise versus meditation on physical and psychological outcomes. Their N was about 300 participants. They found meditation was shown to be more effective than the exercise comparison arm when evaluating the psychosocial outcomes of anxiety, altruism, and life changes. Additionally, meditation was more effective at reducing chronic neck pain, at rest, and pain-related bothersomeness. Exercise, however, was of course more effective in producing physical health-related quality of life, HDL, LDL, fasting blood glucose levels. But interventions that were found to be comparable when evaluating the outcomes of well-being, alcohol consumption, and perceived stress levels were definitely in combination for both of these modes of addressing disease. So imagine if we taught our patients both, exercise and the influence of the mind.
Yeah, not one or the other, but how do we bring this together for ourselves and for our patients? I think that's a really important point. And one of the reasons why I wanted to, chat with you today. I mentioned earlier that paper in JPT of 2016, Physical Therapist Perceptions of Mindfulness. There's another paper that you did author, which I have to mention because you authored it with my former professor, mentor, and good friend, Kirsten Palombero. And I know she listens every once in a while to these podcasts. So if I don't mention, I have a feeling she's going to come back. But can you just tell us what the title of that paper was so we give Kirsten a little shout out?
Yeah, Kirsten is an amazing human being. She really helped me pull this paper together. This was a study called A Mindfulness Workshop for Health Science Graduate Students, Preliminary Evidence for Lasting Impact on Clinical Performance. And essentially, we taught students a mindfulness class once a week. They got together. It was interdisciplinary, PA students, nursing students, all sorts of backgrounds and disciplines. And then we said, okay, go on clinical. And then we took a survey and found that not up to 9 months later, we had lasting improvements in the students' ability to manage stress and really function clinically as their best selves, really in terms of clinical decision-making, safety, relationships, patient satisfaction scores, those sorts of things.
And it's been wonderful chatting with you today, and thank you for sharing all of your research. And I really look forward to seeing if you hopefully produce more of it with regard to mindfulness and PT education, as well as just physical therapy in general. I think it's really important work. How can we follow you, and how can people follow your work?
Yeah, I did participate in a wonderful new textbook coming out called Lifestyle Medicine. And I was just really honored to have written a chapter in that book. So I do hope you pick it up when it comes out and take a look at that.
Great. And that book will be out 2021. But in the meantime, if you want to follow Annette, I will help her out a little bit. You can find her on the website at the Health and Rehabilitation Sciences program in physical therapy at Temple University. It's a great place to reach out to her, whether you're a PT student and you're interested in learning more about mindfulness, or maybe you're a PT professor and you're thinking, hey, maybe I need a little bit of mindfulness in my program. You can find her there and reach out to her. And again, I want to thank Annette for joining us this week. Make sure you share this episode with your friends and family and colleagues on Facebook, Twitter, LinkedIn, or wherever anyone is talking about mindfulness, pain, and physical therapy. And I want to thank all of you for joining me this week, and we'll see you next week.
Thank you, Joe.
Thank you for listening to the Healing Pain Podcast with Dr. Joe Tatta. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrative, painscienceinstitute.com. Sign up to receive weekly updates, leave a review on iTunes, and share this episode with your friends.